covers typical agents. If indeed it demands that we are to give transfusions, normally transfusions are given. Why? Because in these individuals, they have high buildup of the red blood cells with HBS. So at times, we give transfusion tries to overpower the amount of HBS. So the donor blood incoming will make sure that it brings in more HbA to overwhelm the population of the HBS, so that HbA at least will predominate for some time, coming in from the donor's blood. And at that point where you have fewer levels of HBS because of the donor blood, you may have reduced levels of issues with vaso-occlusive crisis, including acute chest syndrome. So you may do simple transfusion or exchange transfusion. They are talking about exchange transfusion. What they do is to remove the patient's blood to outside the patient's body and replace with somebody with HbA hemoglobin in their red blood cells. So it's like you are removing the SCD. Hello?
Please, can you take that again? The transfusion, please.
So exchange transfusion. So what they do is to remove what the SCD patient possess. So yours is full of HbA. So let's say we are taking out 1 liter of your blood full of HbS. Then we transfuse with a donor blood with HbA, hoping that with this, the donor HbA will predominate. Then we are reducing your HbS, which is predisposing you to vaso-occlusive crisis, including the acute chest syndrome. That is what they do. Then the simple transfusion, you don't remove the patient's blood. You keep it, then you add a donor's blood. That one too is there. The target that we allow HbA to predominate and reduce the population, at least temporarily reduce the population of the HbS so as to minimize the assault. Of course, remember that whole blood comes in with plasma. The plasma can precipitate respiratory balance all this against the respiratory issues. In children, you can transfuse 15 ml of blood per their kg body weight. The aim is to increase the hemoglobin levels. But be cautious. Don't go above 10 grams per deciliter. All right. Please, just a minute. Let me see. I'm trying to activate my pointer, but it's not working. I'm coming. It's not working. All right. So let's continue. Now, in severe cases, if the acute chest syndrome becomes severe, as I said, the patient may need a ventilator support. If it's that bad, SpO2 down, everything down, the patient is in distress, loss of level of consciousness, the patient will be at risk of aspiration and issues with hypoxia. patient can tolerate this tube in the adequate analgesia and sedation. Current evidence support light sedation, so don't over-sedate. How do you maintain light sedation? You monitor the depth of sedation with a validated sedation scoring tool. Example is the Richmond Agitation Sedation Score, the RAS score. Target of -1 to -2 should be enough to maintain the patient's tolerance. That is what you do. There's a whole lot into mechanical ventilation, but briefly, this is what we do. The moment you are to be intubated, it means your respiratory responses are very bad. You are having very poor gaseous exchange. That is one indication. And therefore, if you don't allow a machine to do it for you, you are going to create a lot of issues. If you lose consciousness, if your GCS is very bad, normally below 9, 10, then you may aspirate. So as part of the indications for mechanical ventilation, you would want to protect your airways from possible aspiration from reduced or loss of consciousness. We can do that to help you. These are all possible indications for mechanical ventilation. Acute chest syndrome, if it's severe, becomes an indication for intubation. Then, to avoid collapsing of your alveoli, that is atelectasis. That is when your alveoli collapses. The alveoli is not supposed to collapse. If it collapses, it will be very difficult for it to become enlarged again, to be filled with air, and therefore undergo gaseous exchange. So to avoid this, because you get some infections, it can lead to atelectasis. So you do incentive spirometry. So you blow air in and out of a spirometer just to maintain an open alveoli so that the alveoli can still function. If bronchospasm occurs as part of the acute chest syndrome, then you need to relax your airways. What do? You give your beta-2 agonist. Typical example would be salbutamol inhalation. So salbutamol inhalation will relax the airways and prevent or minimize airway bronchospasm. Any queries? So this is how briefly acute chest syndrome is managed. The rest, we give IV fluids conservative way, making sure that we balance our inputs and outputs, not to cause overhydration, because overhydration will contribute to congestions within your chest. That can precipitate the acute chest syndrome. We give you oxygen supplementation, especially when your SpO2 is very low, below 92. Not to give excessive oxygen, because one of you just mentioned that excess levels of oxygen could be converted to reactive oxygen species, and that can harm the patient. So you give oxygen, but don't overgive. You target between 94 to 98%, and that should be fine. You give antibiotic coverage because of high possibility of infections, even contributing to the acute chest syndrome in these individuals. Cover atypicals and typicals. In extreme cases, you can transfuse, and your target is to reduce the patient who is having high levels of HBS. You want to bring in more blood with HbA so that you reduce the assault. In extreme situations, you can ventilate the patient. You do mechanical ventilation. Prevent atelectasis by introducing incentive spirometry. If there is bronchospasm, you relax the airways by using beta-2 agonist. This is how you manage acute chest syndrome in SCD individuals. Any queries? If not, we are moving to another vaso-occlusive crisis complication, that is stroke. As you said, if it happens within the blood vessels in the brain, then it can lead to stroke. This is very common around ages 2 to 11 years. 30% of SCD patients is very, very high. If stroke happens, of course, the usual signs and symptoms of stroke may manifest, ranging from seizures to movement disorders, that is limping, paralysis, either hemiplegia or both sides undergoing paralysis, inability to talk, inability to walk. All these things could happen. Typical of stroke in anybody, just as either hemorrhagic or ischemic stroke may manifest. Main types of stroke that happens in SCD individuals. Ischemic. These patients are at high risk for thrombosis, either from the chronic inflammation, the injury that occurs can trigger platelet attachment and platelet activation, leading to clot formation. The injury can cause thrombus formation. The blockade by the rigid blood vessels can give rise to stasis, and stasis is a high trigger factor for thrombus or clot formation. So ischemic stroke is not surprising. These individuals can also be born with issues like aneurysm or atrioventricular malformation. And these are all underlying issues, etiologies of hemorrhagic stroke. So that one too can occur. But most commonly, it will be the ischemic stroke that will occur in these patients. They can also suffer from silent infarct. No signs and symptoms of stroke. Meanwhile, down there, the patient is having issues. On MRI, we may detect damages there. All these are possible. Take the patient through investigations like full blood count, of course, is the hematology issues. Because of the benefits of transfusion in stroke, remember we discussed transfusion. And of course, it's all about trying to reduce the HBS population, bringing in HbA to help minimize all sorts of vaso-occlusive crises. Grouping and cross-matching will be done, and if contractible blood is detected or achieved or attained, the patient could be transfused to minimize the assault. Do your normal CT MRI to confirm the stroke and to differentiate between the stroke. Since stroke is known to be a common thing in SCD individuals, we can monitor them when they get to this age, 2 to 11 years, to be able to detect any markers that will predispose the patient to. So you can do transcranial Doppler. If it's available, this can be used as a form of monitoring tool to assess SCD patients, especially between age 2 to 11. Where the risk is most high, so that you prevent the patient from getting the stroke. Again, transfusion, as I said, is known to minimize all vaso-occlusive crises. So here too, you can do transfusion. The same in 10 grams per deciliter. You can do exchange transfusion, as I said, removing the patient's blood, which has a lot of HbS, and replacing with a donor blood with a lot of HbA. The target is to make sure that the HbA will now predominate, making the HbS go below 30% of what the patient has. Stroke could trigger convulsions, and therefore, if it happens, anticonvulsant should be given. Embolization is another technique that can be used to minimize a possible stroke trigger. What is embolization? Vice Captain, any idea? Embolization. So individuals who are at risk of hemorrhagic stroke, that is those with aneurysm, those with atrioventricular malformations, these abnormal blood vessels are at high risk of bursting and therefore causing hemorrhagic stroke. We can give, or interventional radiologists or these neurologists can create artificial clots to these blood vessels so that blood will not even pass through them to the level of where you have the aneurysm and cause the aneurysm to break. I repeat, interventional radiologists or neurologists, with the help of imaging techniques, can pass through these blood vessels and create some artificial clots to block blood flow through aneurysms and atrioventricular malformations. Because as blood flow through them with high pressure, that is what leads to the breakage of such abnormalities, and therefore hemorrhagic stroke will occur. So they can use some glues, they can use beads, they can use several other things that can create artificial clots, blocking further flow of blood through that malformation, either aneurysm or atrioventricular malformation. And this will help minimize blood flow with high speed or high pressure through the aneurysms, causing them to break and cause blood to leak. Surgically, these abnormalities could also be repaired. These are there, and of course, it could be employed in extreme stages. Supportive care, of course, based on the type of damage that will occur. So if the stroke happens and you suffer from loss of speech, you suffer from any power within your limbs, you can't function anymore, then issues like physiotherapy, speech therapy, and so on and so forth will come in as a form of supportive care. This is very common in stroke. So it's the same thing we are talking about here, so that it can help you to function. At least it can help you to get your speech back, if not in full. So that is how stroke is also managed in vaso-occlusive crisis or SCD individuals. Another complication that can occur is abdominal pain episode. Why? Because the spleen is found within the abdomen. And the moment you create excessive levels of RBCs with HBS and with continuous exposure to low oxygen tensions, they tend to sickle. So you're having a lot of sickle cells. Your spleen will not sit and allow this to happen. Your spleen will be charged to sequester these abnormal red blood cells and destroy them. The sequestration of these abnormal red blood cells in the spleen can cause pooling of blood within the spleen. It causes splenomegaly and it comes with a lot of pain. The spleen is found within the left side of the abdomen, and this can result in massive pain. So that is how abdominal pain occurs in sickle cell crisis. So the blood vessels that are found within the spleen, the moment they send the blood containing the RBCs there, the macrophages of or as part of the reticuloendothelial system will sequester these abnormal red blood cells. This can lead to the pooling of blood within the spleen, causing the spleen to become enlarged, and it comes with pain. Remember, the blood vessels within the spleen too can get blocked by these rigid RBCs in the blood, and that can also contribute to lack of blood supply to the spleen, causing infarction that comes with pain. So that is how such problems also occurs. Abdominal pain episodes. How do we manage it? Conservative treatment, appropriate hydration with analgesia. The symptoms may normally last between 2 to 4 days. In extreme stages where infections occur, of course, you will have to know the extent of damage. Colonoscopy may do, and if possible, surgical resection may be necessary if you have issues with bowel perforations and other issues. This is how you do it. In fact, if you have 2 continuous episodes of splenic sequestration, it's an indication for splenectomy. Even in childhood, if it happens 2 consecutive times, splenic sequestration, it means it's going to happen a lot, and that can lead to catastrophe, and therefore removing the spleen will be better. Unfortunately, once the spleen is removed, the patient is exposed to infections, and therefore you must be careful to protect such individuals from infections. Priapism, another complication. Priapism is also about vaso-occlusion. So once the spongy tissues of the penis are filled with blood, the blood vessels send blood to the penis. The penis has spongy tissues. It becomes filled with blood. You get erection. After the erection, unfortunately, the blood
Hello,
that's
sir.
in there. Yeah, hello.
Sorry to take us back. At the stroke part, you said if there is aneurysm, we may opt for embolization, where we will introduce artificial clots to prevent blood flow through that particular vessel. Is there not a risk of causing ischemia to the regions that particular vessel might be supplying, or there is something to counter that risk?
That procedure I said will come with surgery. So the moment you block, it's a temporal intervention. So you block to prevent further blood flow. Quickly, through surgical means, you solve the aneurysm or you solve the malformation. Then you abort. Are you okay?
Yes, please.
Hello? Hello? Hello?
Hello?
Yeah. Are you okay?
Yes, please.
Yes. So it comes with surgical repair. So to avoid bursting of the aneurysm, you temporarily block with the beads or glue or whatever thing that they do. Quickly repair the aneurysm or the atrioventricular malformation. You clear the blockage, and then blood flow can resume. I hope it's clear.
It looks like everything has.
Yeah, it's clear.
All right.
So
Okay.
refreshed.
So
it's now. No, it doesn't come yet.
spongy tissues get filled with blood. The sickle red cells, with their rigidity and sticky surfaces, will block the blood vessels, and it becomes very difficult for the blood in there to flow back to create flaccid penis, and therefore they get sustained erection lasting more than 3 to 4 hours. If it happens in this way, it can cause damage and therefore the
Yeah,
person
all
can
of this
suffer
is
from erectile dysfunction.
priapism.
Very common in SCD patients around the age of 20, as high as 30 to 45% incident rates. How do we manage this? If it occurs, you need to relax. You need to relax and do your conservative management. Effective hydration. Remember, dehydration is one of the causes of vaso-occlusive crisis. This is part of the complications. It's painful, so give analgesics. Don't go and give cold baths. You further cause vasoconstriction, so give warm baths. If it doesn't work, you can aspirate and irrigate the corpora cavernosa. So as you put some needle within the corpora cavernosa to remove some of the blood away, then you irrigate with normal saline. You can also give sympathomimetics. To constrict the blood vessel so as to avoid further inflow, especially after aspiration. You inject with a vasoconstrictor so that you don't get further flow of blood into the penis to cause the erection to happen again. So at times you give agents. By here, what we normally give is adrenaline. So we aspirate at 3 o'clock. You look at the glans penis as a clock. Your right hand side, as in western. Yeah, hello.
Sorry, you were breaking at some points, but I heard you say that we don't give cold baths because we want to we worsen the vasoconstriction.
Yes.
But then we are
At that
giving
point,
sympathomimetics to vasoconstrict.
that is when you aspirate. You don't want a refill. Are you okay? So it goes with aspiration. So if you aspirate, you don't want a refill, because if refill occur, the whole condition can recur. So that is what I was explaining. So you consider the glans penis as a clock. So the glans penis, where you have, let's say, 3 o'clock, you can aspirate from there. Then at 9 o'clock, you inject your vasoconstrictor. So as you pull the blood out, you are causing vasoconstriction to prevent or avoid refill. If refill occurs, the blood that is coming in there will come with same RBS, that is sickle. Another episode will occur. So you aspirate, then you vasoconstrict to prevent a refill. Refill can cause the recurrence of the sustained erection. In extreme cases, then the urologist will have to operate and then direct or redirect the blood flow from there through surgical shunting. This is high risk and it may cause or contribute to erectile dysfunction. You can also avoid this by giving the person, by way of prevention, prophylaxis, pseudoephedrine. Ephedrine is a mixed agonist, a mixed sympathetic agonist. On its own, it can act on sympathetic receptors and can also cause the release of sympathetic neurotransmitters, so that it causes vasoconstriction to the blood vessels that supplies the penis. So that vasoconstriction doesn't mean that you are totally shutting the thing, but at least it minimizes the occurrence of priapism. You can also do that. If damage occurs, then psychological issues will set in. The person has issues with erectile dysfunction now, and therefore psychological support, social support, family support, and all those things must come in. This is very common around age 20. Normally, most of them will come to the hospital because of these issues. Priapism, very, very common. Splenic sequestrations, I've mentioned it, and it gives rise to the abdominal pain. And this can be life-threatening. Why? Because it can lead to pooling of blood This can even reduce your hemoglobin levels, creating
Yeah.
acute anemia. It can drop your blood volume because you are going to have a lot of your blood being stuck within the spleen, and this can drop your blood. It can even lead into shock. So how do we define splenic sequestration event as a life-threatening issue?
Hello, sir.
Yeah, hello.
Sir, please, sorry for cutting you. I needed some clarification on the Prapism. I think I've seen somewhere where a patient was put on glutamide as part of the medications. So I wanted to know the role it was playing in the Prapism. If you can enlighten me a bit on that.
Glutamine. Come again, hello.
Sir, please, flutamide.
In fact, I don't have any idea about that. Where was that? And was there any? You didn't ask them the rationale behind that drug.
So, sir, please,
What is it? Mhm.
I saw it in a patient's chart as part of the doctor's report. I saw it added to the patient's medication, the flutamide. I think it's a non-steroidal anti-androgen.
You saw it where? That was as part of your practice.
Yes, please, in the hospital.
And what did you do?
Oh no, I actually saw it. It wasn't my case, and someone showed it to me that there's a Prapism case at the ward. And when we're going through the chat, I noticed that medication added to it. So I just went to search about the drug, but I didn't see its relation with Prapism. That's what I'm asking.
Okay, so what we need to do is to find out. In fact, I haven't met anything like that, but since it has been used, I'm sure that maybe per guidelines recommendations. What I know is, as per my area, acute care, maybe the urology people can explain it better. But in acute care, emergency care, critical care, what I know is this is what we do to stabilize the patient. Maybe further management. The urology people, it may have maybe a role to play, maybe chronic management. I don't have any idea, though. But let's find out. Tomorrow we are meeting, right? We are meeting. So please, let's read on it. Chronic management or the role of flutamide in Prapism. I don't have any idea yet. But as per acute care, these are the interventions that we do. But chronically, maybe apart from the sympathomimetics, this one too is there. I'm sure maybe it will have a role to play. You see, the drug is what?
Sir, please, flutamide.
Yeah, you mentioned it pharmacology class.
Non-steroidal anti-androgen.
Okay. So maybe androgens do have a link with that. So let's see, let's read on it, and then tomorrow when you meet. But next time, if you see anything like this, since that means it was your friend's case, a case that your friend was following.
Yes, please. He was
downloading. So he didn't also find out why as part of the team. You are the pharmacist among the team, and they are using a drug, and you didn't find out why. So what if it was inappropriate? You just allow the thing to just slip through. All right. So next time, if you find anything like that, you need to probe. You are part of the team, and anything concerning drugs, of course, it should be of concern to you. All right. Let's read on it. Tomorrow, you will find out. I'm sure that it will have a key role to play in the chronic management. If not prevention, maybe it will serve a better role or any key role in the management of Prapism. All right. So splenic sequestration. So you can have pooling of blood within the spleen to the extent that it can even drop your HB. This, if you have high levels of blood being pooled within the spleen, It can also lead to a reduction in blood volume. That can lead to hypovolemic shock. All these are possibilities of splenic sequestration events. Signs and symptoms, of course, you have blood stain within the spleen. So splenomegaly is possible. Spleen is located within your left abdomen, and therefore, if you feel any pain, it will be there, your left side of the abdomen. It's creating a drop in HB. You are going to have pallor. Signs of shock, because you are not going to have that volume of blood in your blood vessels anymore. So you can get hypovolemic shock, anemia, weakness. And of course, once you have this level of anemia, you are going to have reduced oxygen supply to your brain. That can lead to loss of consciousness. These are all possibilities in splenic sequestrations. As I said, once you have 2 episodes of splenic issues, is an indication for splenectomy. Unfortunately, the spleen is part of our soldiers. Our immunity, spleen plays a very critical role. And therefore, once you remove the person's spleen, remember that you have predisposed the person to infections. And therefore, you must protect the individual from infections. So it starts all the way from lifelong prophylaxis. Even with the spleen intact, the spleen could be functioning abnormally, or the spleen can get damaged. Individuals with sickle cell disease, we know that as part of these issues, they are always at risk of infections, and therefore we normally put them on antibiotic prophylaxis. So lifelong antibiotic prophylaxis will be given. Remember that the infections that could be prevented through vaccination, you make sure that the individual will receive all the vaccines and become immunized. These are all forms of protecting the patient from infections. Once the spleen has been removed, the patient is exposed to infections, and therefore you must protect the individuals. Again, it is part of the occlusions, and therefore attempt to minimize the HBS population could be done through transfusion, but you have to be cautious. Don't overload the blood to cause congestive issues or to precipitate congestive issues, especially if the patient is having issues with heart failure, or it can even cause heart failure. So over transfusion can contribute to heart failure or can precipitate heart failure while you are introducing excess amount of fluid. As part of the management, splenomegaly is there, and therefore the patient's relatives, for example, mothers, fathers, can be taught on how to detect splenomegaly. And as they palpate and realize that the spleen is becoming enlarged within a very short time, that could hint you that splenic sequestration is happening or has started, and therefore the necessary thing is to rush the patient to the hospital for adequate management. As I said, the pooling of blood within the spleen can cause hypovolemic shock. And what do you do? If it is blood that is causing it, then you need to replace the blood. Before you get blood, you can throw in your crystalloids or your colloids to resuscitate the patient before maybe you are able to secure your blood. Else, the hypovolemic shock can cause damage. Be careful not to overload. That is very, very important. Always try to continuously monitor your spleen. You palpate. Monitor your full blood count. You are introducing transfusion. The target is not to go above hemoglobin of 10 for reasons discussed earlier. This is how splenic sequestration event as part of the complications is done. Another issue is aplastic event. Once you mention aplastic, then your focus should be on the bone marrow being damaged, aplastic event. These individuals, because of either functional spleen issues or the spleen getting damaged, they are prone to infections. Notable infectious agent that can cause aplastic issues is parvovirus B19. Once the patient is at risk of infections, it is very easy for that individual to get parvovirus B19 infections. If this happens, then it can cause massive damage. The infection, this virus can cause massive damage to your bone marrow, contributing to the problem of aplastic event. Now, we all know that sickle cell crisis will cause hemolysis because of the abnormal nature of the red blood cells. Sickle cells will be hemolyzed by the spleen, at least we know. And as part of the responses to hemolysis, you expect to see a rebound or increased production of RBCs to try and then replenish or to try and then balance what we are losing. So you get reticulocytosis, that is increased levels of reticulocytes as a response to the hemolysis. That is what happens in all hemolytic issues. But the moment you get parvovirus infection and it attacks your bone marrow, this is what happens. The usual response of increased reticulocyte synthesis will not occur because the manufacturing site has been destroyed by the virus, and therefore the hemolysis will not come with reticulocytosis, but rather reduce reticulocyte formation. So what you have, they are undergoing hemolysis. The normal response is to increase erythropoiesis. And the evidence is that on the full blood count, you will see reticulocyte increasing. With this type of complication, that is aplastic event, typically caused by parvovirus infection because the patient has reduced immunity. This virus is going to attack your bone marrow and the hemolysis will occur, but you cannot produce enough reticulocytes. Why? Because the bone marrow is destroyed. So you have reduced reticulocytes with evidence of hemolysis. Instead of the usual picture in all other hemolysis, in all hemolytic issues, you have evidence of hemolysis, that is decreased haptoglobin, increased LDH in the blood, you have jaundice, you have Coca-Cola-like urine, with high levels of reticulocytes on the FBC. That is the usual picture of all hemolytic problems. But with aplastic event, the usual picture of hemolysis will be there. But on the FBC, you are rather going to have reticulocytopenia. Why? Because the manufacturing site has been attacked by the parvovirus. A very serious indication, a very serious occurrence. How do we manage? How do we manage? Of course, you do your full blood count and you see reticulocytopenia, reduce reticulocytes with evidence of anemia, of course, low HB. Low HB. How do you manage it? Supportive transfusion Again, trying to bring in proper red blood cells with the proper hemoglobin, HbA. Please don't overshoot. Don't overshoot. You can give IV immunoglobulins to neutralize the virus. So in severe cases, you will have to neutralize the virus. And therefore, IV immunoglobulins may be needed to go in and neutralize the parvovirus so that we don't get aplastic events again. This is how aplastic event occurs and how it is managed. This is also possible in a sickle cell individual. Any queries? Any queries? Any
Hello, sir.
query? Yeah, hello.
So, sir, with the aplastic events too, will your HB target still be 10?
Come again.
You see,
Your HB target.
earlier-
Yes, of course.
Yes.
As for the HB, yes, it is low. Increase it, but don't be too ambitious. We don't want you to overdo things. Give it, don't go more than 10. 10 is okay, the patient will be fine. You even have individuals with HB around 9, around 10, but they are okay with it. But clinically, you will say that they are anemic, but that is how they are. So don't overshoot. Don't transfuse. Let's say the person is at 6. Approximately 1 pint will give you 1 HB, 1 gram per deciliter. Don't go and give 6 pints to move the patient to 12. Be careful. Are you okay? Be around 10. Yes, to avoid any issues. Be around 10. You have to be careful. The same thing is what we do in erythropoietin administration to avoid hypertensive crisis and a lot of thrombus formation and those things. Don't go above 10. 10, once you hit 10, you are good to go. Any other question? Any other? All right, let's look at hyperhemolysis. This is obvious. You are presenting useless red blood cells. Of course, they will be destroyed. But vaso-occlusive crisis, if it happens from any of the underlying cause, be it an infection, dehydration, and again, if you are not lucky and you have additional issues like GCPD, so somebody could be so unlucky that the person could be GCPD and at the same time sickle cell. Remember, GCPD is an enzymopathy, is an enzyme defect issue, and sickle cell disease is a hemoglobinopathy. If you are not lucky, you can get the two, and both are high risk factors for hemolysis. So the two combined, it will not be surprising that the patient will always present with high degree of hemolysis. The good thing is that unlike aplastic events, with hyperhemolysis, you are going to get the normal response of enhanced red cell synthesis. And therefore, the person will tend to produce more reticulocytes in an attempt to replace what he or she is losing. So to differentiate it from aplastic events, you realize that on the FBC, the person with hyperhemolysis, not aplastic event, will have reticulocytosis. Please, can you hear me? It's raining here. Can you still hear me?
Yes, please, sir.
All right. So to differentiate aplastic events from hyperhemolysis, you realize that unlike aplastic events where the person cannot produce reticulocytes, with hyperhemolysis, the person can produce. And therefore, on the FBC panel, you will see reticulocytosis. And of course, further analysis will give you a clear picture of the signs, symptoms, and all the markers of hemolysis. Increase LDH, decrease haptoglobin, increase bilirubin levels, jaundice with Coca-Cola-like urine. These are all manifestations that you see. So in hyperhemolysis, this plus reticulocytosis. In aplastic events, all the indications for hemolysis, but there will be reticulocytopenia. How do we manage? Again, the target is to make sure that HbA will predominate and we reduce the HbS. So blood transfusion. Packed cells is preferred, of course, volume issues. We don't want to cause any issues. Hydration is very important because dehydration is a trigger to occlusive crisis that can give rise to a lot of multi-organ dysfunctions. Treat any other underlying trigger factor. So EDD. And there are oxidants contributing to it. Clear. Infection. Clear. Dehydration. Clear. Acidosis. Clear. This is how you do it. You manage the underlying causes. Any issue. So you realize that we've gone through a lot of complications, from trapezium to hyperhemolysis to acute chest syndrome to aplastic events, splenic sequestrations, a whole lot. And most of these are very, very common in vaso-occlusive crisis. Stroke. These are all problems. So underlying cause or etiologies of stroke must be checked well. Make sure that the patient doesn't suffer from dehydration. Protect the patient from infections. Protect the patient from acidosis. Any simple thing at all, hypoxia or hypoxemia, make sure that you protect the person, because any of this could trigger vaso-occlusive crisis. And vaso-occlusive crisis will lead to any of the complications, ranging from acute chest syndrome, stroke, trapezium, aplastic event, hyperhemolysis, and any other acute organ disease. Any issues. So these are
Hello,
the
sir.
complications. Yeah, hello?
Yeah, can you please explain the link of the hyperhemolysis to the G6PD deficiency patients? I didn't
No,
get
we are
that.
talking about in a situation where the person is so unlucky and the person is sickle cell and also has additional risk factors for hemolysis like G6PD. It's not like the hyperhemolysis will lead to G6PD. You can get an individual with G6PD plus sickle cell. So two troubles. All of them are high risk factors for hyperhemolysis. Are you okay?
Yes, please. Thank you.
All right. Any other periods? Any other? So these are the acute complications, the most common ones that can happen, and the underlying cause is vaso-occlusive crisis. Anything that can contribute to vaso-occlusive crisis, please protect the patient. Infections that comes with fever, acidosis, dehydration, hypoxemia and hypoxia, and what have you. Please make sure that the patient doesn't suffer from. Infections are common because of their spleen issues, and therefore you must protect them. Either you give antibiotic prophylaxis or any vaccine preventable infections. Make sure that the patient receives that vaccine, because the patient is at risk of infections. Reduce immunity in this patient. The spleen is always in trouble. All right. Okay, let's continue. Now, let's look at the chronic management. What we have discussed so far are the acute issues. But chronically, how do we manage these individuals, SCD individuals? So pharmacologically, drugs like hydroxyurea, crenezalizumab, folic acid, at times inhaled nitric oxide or L-arginine, that is a precursor of nitric oxide, antiplatelet, prasugrel ticagrelor, L-glutamate powder, which reduces oxidative stress, and voxilota, which is against polymerization of HBS. These are all drugs that could be employed. But notably, hydroxyurea stands out, and folic acid. Hydroxyurea and folic acid are very common in our setting. Yes, but hydroxyurea is very important in our setting. And of course, folic acid administration. Because of high levels of destruction of the RBCs, the body also step up its production. And therefore, the body's demand for folic acid increases so that we can produce appropriate RBCs. So demand for folic acid. You need folic acid for protein synthesis. Red blood cell contains proteins. So you need folic acid. The demand goes high. That is why we routinely give folic acid for STD patients. Hydroxyurea is key. We are now going to look at these individual drugs, their role, and how they help in the chronic management of SCD individuals. Now, hydroxyurea is an anti-metabolite, can also be considered as a disease-modifying agent. We have a lot of disease-modifying drugs. They can actually interfere with the natural cause of certain diseases. Most other drugs, when you use them in especially autoimmune diseases, they just control signs and symptoms. But drugs that are classified as disease-modifying agents, they actually modify the natural cause of the disease, and they give us proper control than those that control just signs and symptoms. Now, how does it work? In SCD, hydroxyurea, it diverts the production of hemoglobin to the fetal type. Remember, one of your colleagues, Scott, just mentioned that between HbF and HbS, HbF is better, though it is the hemoglobin that is found in children. It is still better because as for HbF, when it is exposed to low oxygen tension, it doesn't sickle. HbS, when exposed to low oxygen tension, it gets destroyed. Obviously, HbF is better. So if you have a drug that can convert or divert the production of HbS to HbF in adults, yes, the person is an adult, but it is better for you to get HbF than to get HbS. And that is what hydroxyurea does. It also decreases white blood cell and platelet count. Can somebody explain why this is also important in sickle cell disease? Why do we need to decrease WBC and platelet in sickle cell patients for their chronic management? Any idea? Remember, decreasing it doesn't mean that you are shutting the whole thing. So don't be thinking along that way. You decrease it to a certain level for a certain purpose. And that is what I'm asking. So can somebody tell us why this role of hydroxyurea is also important in the management of SCD?
Hello, sir.
Yeah, hello.
What I think is the production of red blood cells and white blood cells are within the same line from the pluripotent stem cell, right? So we want to decrease white blood cell so that there will be increase in red blood cell production.
That is in part. That's a good try, fine. That's in part. But in SCD, remember, we said there is always chronic inflammation, if not from an infection. The person is always having chronic inflammation. And the moment you have chronic inflammation, and you produce more white blood cells, what happens is that neutrophils, a type of white blood cells, they are always activated the moment they see infections, especially bacterial infections. And you get increased attachment of neutrophils to the endothelium. Once you get increased attachment of neutrophils within the endothelium, you are causing inflammation. With this, the inflammation can destroy the lining of the blood vessel. And together with platelets, you get platelet attachment, platelet activation, and therefore thrombus formation. So the target for this reduction here is to minimize, especially the absolute neutrophil count, so that even when you have the infection, the amount of attack, the amount of response from the neutrophils will be minimal, so that it will reduce the inflammation within the endothelium. And also with reduced platelet count, you get reduced clot or thrombus formation. That is how or why decreased WBCs and platelets is also important as part of the benefit we get from hydroxyurea. So it's not only about the HbF production, also trying to minimize inflammation. Neutrophils count, if it goes down, you get fewer attachment, fewer inflammation. It goes down with platelets, even if the platelet to attach to the exposed collagen within the blood vessel to get activated and finally contribute to thrombus formation. So it reduces vaso-occlusive crisis by this pathway. That is what I'm trying to say. Then it also ensures minimal effect. Yeah, hello?
Please, it's time. It's time for a break.
Oh, okay. I nearly forgot. So 5 minutes. So please let me know when the 5 minutes is over, or 10 minutes. Let's do 5 minutes. So kindly let me know when the 5 minutes is over. All right. So 2:32. Let's come back at 2:40. 2:40. All right. Let me try. Then reset this thing. I don't know why it's not working. My pointer is not working today.
network. Yeah, the Wi-Fi. I'm refreshing it.